Hello, I'm Justine Larson. I am the medical director of schools and residential treatment at Shepherd Pratt, and I'm here to bring you the ACAPS lecture series, Making Systems Work in the Era of COVID. And I'm going to be talking to you with several of my colleagues, Kay McGinty and Lisa Fortuna. And we're going to be talking about some different challenges we've run into in several different systems and how COVID has impacted kids with complex mental health needs. Just a moment to tell you about our disclosures. We basically don't have any. I work for Shepherd Pratt and have no disclosures. Here are some of the educational objectives for the lecture today. We will be talking about the intersection between systems impacting youth with complex mental health needs and the impact of the pandemic. We'll be considering some of the systems of care concepts and models and consider that in relation to COVID. We'll be talking about specifically families and youth in some specific settings like rural areas and residential treatment centers. And we'll be working to gain a greater understanding of how to engage a systems of care approach. We also will be talking a fair amount about disparities as well. So as I said, we're going to be presenting sort of a case examples. So the first one I'll be talking about is the COVID outbreak in a residential treatment center, and how that has impacted some of the kids with these complex mental health needs, and how some of the challenges we've run into have really speak to some of the specific issues that these kids and families face. Dr. McGinty is going to be talking about how rural areas have been impacted. And then Dr. Fortuna is going to be bringing it together with some important concepts to discuss and also some potential solutions. We're going to think about what we can learn and also what can child and adolescent psychiatrists do. So probably everybody knows, but the picture there is a picture of our COVID virus that is causing so many problems here. I'm going to give you a case example. I came to work at Shepherd Pratt, which is, in case people don't know, is actually the largest, one of the largest mental health nonprofits in the country. And being the medical director for both residential treatment and schools, so day schools, which are currently not open. But the residential treatment obviously is open. And so I'm going to tell you a little bit about an outbreak that we had here at the residential treatment center and some of the things that this outbreak has brought up. And I'm going to present you guys with the challenges and problems. And I don't pretend to have all of the solutions yet, but I think it's just sort of thought-provoking about how our kids and families are impacted. So on June 16th, a resident came actually from a group home, a girl. She came she actually had a negative COVID test that was sent to us, and she was admitted to the residential treatment center. As the protocol that we have is we keep the kids on the unit for 3 days isolated in their rooms, which is a challenge in and of itself, and to monitor for any symptoms, even after they've had a negative test. But the next day, she developed vomiting, but no fever. We decided to test her for COVID, and she tested positive. She was isolated to a separate location. Actually, during that time, she was restrained a number of times and really struggling. As you can imagine, it would be really scary and hard to be. This particular child had really significant trauma history, didn't know anyone, was in this new environment, and then basically was sort of by herself. I'm sure it was very scary and very distressing. About 4 days later, one of the staff members fell ill actually during her shift we had been taking temperatures when people come in, and they had gotten the screening questions that probably everybody is very familiar with. But she developed a fever during her shift, started to feel sick, got tested for COVID and tested positive. A few days later, then 5 more girls tested positive for COVID, and they were supposed to be confined to their rooms. And then a few days after that, an additional girl, and then a few days after that, we had 3 additional girls. So it was basically an outbreak. So I thought I would talk a little bit about some of the patient factors that came up in the setting with complex psychiatrically ill kids. One issue that we ran into was that the kids began to, a couple of the kids really had a lot of behaviors that were amped up, I guess you could say, or that staff received really differently because they were COVID positive. One resident, for example, began charging at the staff and purposely spitting under their face shield. It was almost like the resident behaviors were sort of weaponized or perceived as weapons in a different kind of way by the staff. There were demands to really heavily medicate residents in a different kind of way. And so the demands for sort of the behavioral needs and expectations changed. There was a lot of staff anxiety. At the same time, the residents have become increasingly frustrated and bored and anxious, being confined to their rooms. You can imagine that the kids have really significant, complicated psychiatric histories and behaviors, and so being stuck in their rooms, even if you have tablets and other types of things, it's really challenging. A second thing, staffing factors. Staff started to really call out sick, getting notes from their doctors due to co-occurring conditions saying that they could not work in a place with COVID. And we really ran into a lot of staffing challenges. Out of that came this feeling that staff were not being protected adequately. Also, it brought up a lot of some racial disparities in the institution. The majority of staff, milieu staff, the line staff, are African American, and from Baltimore, an urban area that was hit hard by COVID. There was a feeling that the staff were not being adequately protected, and that staff, being largely African American, were not empowered to make decisions that were really impacting them in the context of everything that was happening with George Floyd. So that was another important thing that came up. Also, community factors really have come up as well. Family members falling ill with COVID. And also visitors and passes not being allowed as part of the infection control policy, which are really a core component of residential and discharge planning. DSS and CPS are having a lot fewer placement options. Foster homes are not really accepting kids during this pandemic time, or very limited numbers of foster homes. DJS also having a really variable response in terms of one child was discharged basically very abruptly without proper planning because the lawyer was able to make the case for the child having a co-occurring condition. And at the same time, other kids seem to have gotten stuck for longer periods. So there's a variable response with DJS. Also, remote learning. When upon discharge with even less structure, not having the usual structure of school, and putting a major strain on families to provide more supervision upon discharge. And a lot being asked of kids in terms of making their own structure, trying to manage their academics. So thinking about our systems of care principles, and for people who aren't familiar, the CAST principles are really one of the principles that really the systems of care model was built on. And the idea behind the CAS principles, the Child and Adolescent Service System principles, are that the services should be child-centered, family-focused, community-based, multi-system, culturally competent, and least restrictive. So you can imagine in a situation in which you have COVID and on a residential unit, some of these CAS principles are challenged. Oh, and by the way, some of these pictures, like from this Voices of Youth website, are done by youth as part of this Voices of Youth program, which is a UNICEF youth advocacy program. And I thought they would be nice to include. So thinking about the different CAS principles, the first one, child-centered services should meet the needs of the child and consider the child's family and community context, and are developmentally appropriate, strength-based, and child-specific. So how do you think about child-centered services in the context of residents being confined to their rooms? So, doing therapy by Zoom, for example, or trying to help the kids think of ways to sort of stay busy and do all the things that they need to do, but being in their rooms. Sometimes it can happen that the needs and safety of the staff sometimes can feel pitted against the residents' need for therapeutic contact. So is it better to have for example, to do the therapy in person, or to reduce physical contact? And is there something missed for the child if the therapy is by Zoom? And then the conflict between the high importance of residents staying in their rooms and then their mental health. So those are a couple ways that sort of child-centered care is challenged. Family-focused care, similarly, we have tried to, we've done a lot more family therapy by Zoom. We've also been able to have some family meetings outside where family members can come outside and meet the resident and talk with them and work with them outside. So it has happened that sometimes residents have been discharged without passes that would usually occur, which isn't an ideal situation, but at the same time, it feels ethically wrong to keep them longer because we can't do passes. Community-based services are also different. Fewer home-based services. In some localities, kids can't get those home-based services, so families with special needs are struggling without home-based services. In terms of the multi-system coordination, again, DSS has more limitations on the different types of placements they can use. Things are variable and unpredictable in the justice settings. Some of the justice settings, the systems want to basically discharge the kids as quickly as possible, keep them out of congregate care, and others basically have frozen things as they are. Also, schools with remote learning, all these different systems and structures that are challenged. Culturally competent, I mentioned some of the issues among staff, but also the community, African American communities and Latinx communities under high levels of stress and dealing with COVID in a different way. And then even more in terms of the least restrictive, in some ways COVID is presenting challenges where infection control is calling for even greater restriction. And that the spitting and other types of behaviors for the kids who are testing positive becomes a more dangerous kind of behavior. What I wanted to do is just kind of present some of the challenges that really we're still in the middle of, and kind of think about those challenges in relationship to the CAS principles. Some of the things to kind of, that particularly I think are that sometimes the staff and the staff needs can be at odds. I think this can happen too in schools where we see that some of the staff are not wanting to work at the schools when the kids are there because of COVID, because of risk to themselves. youth with SED and complex needs are impacted disproportionately by this pandemic, and pre-existing vulnerabilities really are highlighted by COVID, just as they are with many disasters. But it still remains really important to think about our principles of care and to think about these CAS principles even when we're under stress. So I'm going to pass it next to Kay.
Thank you so much, Justine, for that important presentation about how this pandemic has affected care in residential centers, which are so important in our work, as we know, because as we try to keep teens and children in the community, sometimes they need more intensive services. And today I'm going to talk about the COVID-19 system of care response in rural areas. And I'm going to talk about the Carolinas because as some of you who know me know that I was in North Carolina until just recently. And so I was in the eastern part of North Carolina, which is extremely rural and is actually under either tropical storm or hurricane watch right as we speak today. And now I am in South Carolina in the mountainous region, or maybe I should say hill region for the people in the western part of the United States, which is also very rural. So I'm going to talk about how this has affected rural areas, particularly in the South. And if you'll advance the slide for me, please. Justine's helping me like we do in systems of care. This gives you a little idea of where I am now. It's in the western part of South Carolina. It's in the mountainous region. So I'm in Greenville, South Carolina. And these are some of the partners. I work for Prisma Health now, and I have no disclosures. Go ahead. So where I am currently, South Carolina, as most of you probably know, borders North Carolina to the north and Georgia to the south, and they kind of come together over in the western corner. Prisma Health actually spans 21 counties. The northern part is called the upstate, which is 10 counties, and the more southern and eastern part is called the Midlands, which is 11 counties, and this represents about 2.7 million residents, and that's about half of the state of South Carolina, because South Carolina has just over 5 million people. So what has happened here in South Carolina, but also what happened in North Carolina before I left, in rural areas in outpatient care, telehealth exploded after COVID. When I was in North Carolina at ECU, we had been in the telehealth business for over 30 years. So we always did telehealth. But across North Carolina, that was not true. And that is also true about South Carolina. Here in the upstate, they had not done that much telehealth before COVID, but they switched within a few weeks, which you are going to see. This is in a clinic that takes care of children and teens that are in rural areas. What they saw was an increase in their outpatient visits, a definite increase in access to child and adolescent psychiatric services. They were astounded by having essentially no no-shows, which everybody in healthcare understands, which is when someone doesn't come for their appointment for the many reasons that happen. So they were having almost 100% attendance. The patients and the families talked about how much they enjoyed seeing their physician on telehealth and that it was much easier. And many of the child psychiatrists talk about how they felt like they learned more about the patient and their family through using telehealth in the home as opposed to telehealth in a clinic setting, and that they learned more about the home, the environment, the family members, just all kinds of things, including pets. And sometimes the children or teens would show them their favorite activities, show them different things that they had done. And a lot of both the practitioners and the residents and fellows told me they really enjoyed that. And so seeing the patient in the natural environment really helped them. This is in that one clinic at Prisma that I was talking about that sees primarily children and adolescents that are from rural areas. And you can see that in early March, before COVID really hit in South Carolina, that you see a dark blue. Those are in-person visits where someone would actually come to the clinic. But then it was about mid to late March when the governor of South Carolina started asking people to stay home and not go to the doctor or other places where they actually could get infected. And that end of March is when they converted, and the light blue are the video visits. And you can see how fast they converted and how the numbers over time went until mid-July. There have been issues with telehealth, though, in the Carolinas. This is true of North and South Carolina, maybe true of every state in the Union. There are definitely some problems with broadband internet access. This is especially a problem in the rural areas of the Carolinas. Both of the state legislatures have been working on this for some years, but there is a real fever pitch now to work on it, because in the past it was sold that it was important for business or general needs, but now people realize that you need internet access for health and safety, and of course that is always a priority of government. And so the state legislatures are looking into it more, and there are some nonprofit groups that are really pushing that in both the Carolinas. And some states and organizations really worked particularly on providing hotspots. And I know that in, I think, both the Carolinas in particular, when the schools converted to online, that they had to help some areas come up with hotspots so that the kids could actually get some instruction. Now, although it seems like in the rural areas, those of us that treat patients that are in rural areas, that the child psychiatrist appreciated the telehealth visits and being able to go to people's home through the online capabilities, it wasn't really that helpful in some ways for some other services. And so we'll talk about that. But one of the things that has come is collaborative care and embedded care have really been emphasized in the Carolinas since then. Collaborative care has been pushed in both of the Carolinas for the last few years, and actually in North Carolina it is paid for by Medicaid, which is very helpful. And so there's an increased importance at this time to use collaborative care, embedded care, and hybrid models. And primary care physicians are very interested in this now and are seeking partners at a more rapid rate. And it seems like from what the pediatricians have told me here in the upstate, that their numbers of patients decreased for things like well child visits during COVID, but their services for behavioral health have actually not decreased. So that's kind of an interesting point that I have heard. And telehealth is used frequently in the Carolinas with these models. So telehealth, collaborative care, and embedded care have proved to be very important during COVID. This is just a nice picture close to where I am. There are lots of concerns in the rural areas about what has happened with families and children that we see since COVID-19, and I'm sure this is true of many places, but maybe more astounding in these areas. The families are tremendously stressed in rural areas right now. Rural areas typically have people that have a lot of psychosocial stressors during quote unquote normal times. But now with children home most of the time, people out of work, lots of worry about finances, there's a lot of concerns. And there's a lot of worries about increase in domestic violence and child abuse. And actually, I've heard from colleagues that there is definitely some numbers both in North and South Carolina about increase in child abuse. And as Justine said, there's a tremendous concern about the kids being out of school, especially kids that are in special education, because children in rural areas already have trouble at times getting what they're supposed to get when they have a special ed designation, but now it is extremely difficult to get what you need. And parents have told us over and over they are not trained, they are not educators, and they certainly do not know how to teach their children that have special needs at home. So this is definitely a problem. Food insecurity has been a problem in the rural areas for years, but now it is particularly challenging. In the school systems, they have had a lot of creative solutions, including, the bus drivers seem to know kids more than anybody does in the South. And in many school districts, the bus drivers, along with the school social workers and counselors, were making rounds twice daily with meals, and in the summer they have continued to do this. Usually it's down to once daily. There's also a lot of backpack with food programs that are called different things in the Carolinas. And of course, there has also been voucher systems for school systems for kids that have free or reduced fee lunch. So there's a lot of that has happened. The food banks are working overtime to try to help families and children have enough food. And the food banks in both North and South Carolina report an unprecedented need that they have never seen to this point. The access to childcare in the rural areas is basically falling apart. It has always been a problem, but now it's a critical issue. Many of these child care facilities cannot make it anymore because of costs and lack of staff and other problems. And now parents who are working outside the home and actually leaving home to work are having a much difficult time finding care. And there's always been transportation issues in the rural areas, and those continue. Some more concerns, of course, housing concerns. Many people are having problems paying their bills, including their housing costs. In some areas, and there have been some decrease in the time period you have to pay your bills. Many people are having trouble with the cost of just basic services like utilities and water. There are a lot of people that are unemployed now, and they're very worried about their unemployment benefits. Many of the parents of the children that we treat have dangerous jobs, like Justine was saying. They work in situations where they may be exposed to COVID and don't feel comfortable about being at work. A lot of these people are living paycheck to paycheck and missing those social connections that help keep them energized and hopeful because of COVID. And basically having children at home all the time is very difficult, and there's little time for adult activities. There's also some population concerns, since we're talking about systems of care and we're thinking about obviously our individual patients and their families. Some long-term effects that we're worried about are how is this going to affect the development of children and teenagers, and I'm sure we will see a lot of different effects over time. Of course, we're also worried about how it affects the families. And in a larger context, we're worried about how it's going to affect entire rural communities, which have been struggling for years, but this actually may have even more dire consequences for rural communities. And there is a disproportionate effect on members of minority and disadvantaged families, and rural areas in the Carolinas have many of these members. And there's also concerns about what do you do with concurrent disasters, such as hurricanes, tornadoes, fires, floods during COVID-19. And actually today in the Carolinas, sometime later tonight, there will be a hurricane. And what's frightening is that some of the areas have not been able to open shelters because of COVID-19. So we're actually seeing it live. So there are lots of community initiatives. And like in the system of care world, we always want to promote community initiatives. And many communities have nonprofit organizations and community organizations that have really stepped up to help children and families. And in the rural areas in the southern US, like many areas of the United States, there is a strong ethic about taking care of your own, and that continues. But one of the things that we have seen is that the COVID-19 pandemic is so long that it is really taxing these resources. So we're still learning how to keep helping even months later. And just to help you have a moment of peace, this is right down the road from where I work, which makes it feel a little bit better after the topic. And I appreciate everybody's attending our presentation.
Thank you, Kay and Justine. So I will continue in talking a little bit about inequities in COVID-19 from the context, a more urban context, here in San Francisco, California, where I am. This is just a mural in the area where I am, which is in the Mission District of San Francisco, where there is a very present immigrant and Latinx population, which will be a little bit of the center of my discussion, given the disproportionate impact on that community. So let's talk about in what way. So in San Francisco, even if we look at the hospital where I am, which is San Francisco General Hospital, where I'm the chief of psychiatry, and just to sort of reiterate, I have no other conflicts. I'm just employed by San Francisco General and UCSF. What we found is that the majority of the critically ill in our intensive care units were Latinx, about 80%. The Mission District decided that the UCSF, in collaboration with community partners, really the community organizers, worked together to do testing in the district to really see what was the prevalence of COVID-19 positive individuals. And almost 3,000 people were tested, and actually since this slide, there have been additional testing. But what we know is that 45% of individuals tested were Latinx, 95% of those testing positive were Latinx, 0% were white, and again, 80% of the ICU admissions were Latinx. On follow-up, we followed up with people who were in the ICU to be able to provide post-ICU care, both medical and psychiatric mental health and neuropsychology. And 40% of those were without any follow-up after the ICU and had no primary care to follow. There were similar patterns of disproportionate critical care and deaths, I think, that we've been seeing across the country in terms of the Latinx population. And we know that there has been racial ethnic disparities in regards to death rates around the country. And this particular slide shows us that even in the 35 to 44-year-old population, which we would consider a younger population, there has been disproportionate deaths among Black as compared to white, so 10 times higher in the Black population, and 8 times higher in the Hispanic, Latino, or Latinx compared to white. That goes pretty much across the board in age ranges, except in much older, 85 and up, where it's more similar. But this does sort of show what we saw in San Francisco, where a good proportion of the people who were positive were in that 35 to 44-year age group, low-wage workers. So what we knew is that what was being superimposed, this COVID-19 was being superimposed on disparities that were already existing, that have an impact on not only the adults, but obviously the children in the community. what we've seen is that as we've dug deeper, that with the disparities that have been seen with or worsened by COVID-19, that we really need to access more culturally appropriate care, address language barriers. What we're finding is that even with community-based organizations that are providing services like food access, financial assistance, immigration policies, and the fear of the public charge, that if you're seeking social services support, that might imply some negative indications for your immigration status and applications. Those have kept some people away, but we've had to do a lot of psychoeducation or education, community education around that you can access services. Poverty and inequality, distrust of the healthcare system and stigma around mental health, and then the inadequate support for safety net settings of how are we going to actually provide these services, medical and mental health, for low-income populations, and having sufficient resource to do that. And then food and housing insecurity, and then the lack of care coordination across systems, especially as multiple systems have had shut down through this pandemic. So some of the things that we have tried to do is really have a community-focused approach, in that systems of care approach of really being sort of community and family-centered. And we held a focus group of community promotoras or community outreach workers who were really working with families around financial issues and economic progress. And what they're finding in terms of their needs as promotoras is that really mental health is one of the primary areas that they're seeing that there is a need. One is child mental health issues. Parents and families very worried about anxiety and increased depression and withdrawal from their children across the age ranges, and really struggling with keeping up with their education during the school closures and virtual learning. Parental unemployment and financial crisis, depression and anxiety in the family, adults and children, an increase in alcohol and substance use disorders or increased drinking, the problems with individuals really having physical and psychological impairment after having COVID-19, and the difficulties of the recovery period, unsupported special education and healthcare needs, much less use of, as Kay was talking about in where she is, there's been less healthcare use. Family conflict, stress, and violence with less child protection reporting, and increase in suicidality. So this is what the community has described as their priorities. And so, this little sort of salud mental para su familia is at least an educational series that we started to be able to help families think about these mental health issues and figure out how to, access care where it is available. So one of the things that we have found that's really important is that the community has really tried to step up and try to fill some of the holes in supports. And this also has a little bit of a handout of the Latino Task Force or Latinx Task Force in the mission, where they have created a hub where they're providing these different resources for COVID-19 to the community. And you can see it goes everything from health and food assistance to helping artists and artisans who rely on that work for their life and to be able to sustain their homes, as well as small business assistance, housing, employment, economic relief. And we have felt that we also have had to try to figure out how to partner in terms of building telehealth capacity and networks across child serving systems. And one of the things that we have found similarly is that, even with the difficulties in people having access to the optimal telehealth, in the combination of video and telephonic outreach, we've been able to maintain our volumes, at least here in the hospital, for child behavioral health services after a dip, and then we went back up, and we are also showing much less no-shows, even within the Spanish-speaking population. Partnerships with community-based organizations have been critical in terms of trying to figure out how do we continue an interconnected system with families. It's been a little bit challenging being able to work with mental health with schools because the schools are also so impacted and have been closed and stressed to try to figure out how to provide educational services. But we are, which I'll talk about, finding ways to interconnect a lot more so that we can have more collaborative care. Ensure adequate stimulus and employment funding is one of the things that we're really fighting for, including for immigrants, because the financial stressors have been very significant around mental health. And how can we sort of work together to preserve all the treatment and recovery support services that we need in this time for the long run. Increased funding for evidence-based suicide prevention services is another thing that we are trying to support, because these lines have been at least critical in trying to help address some of these more acute issues. And that we're starting to engage also in some research on how do we implement some innovation in addressing child mental health in this era of COVID-19. You know, as Dr. Larson was talking about, you know, we've also seen challenges for institutions and systems involved youth. There's been a disparities in technology access, high levels of staff and parental stress, as you know, as Justine definitely illustrated, due to prolonged family separation, no visits, quarantine, the disproportionate educational disruption, and the lack of staffing to maintain that educational support. And then that just contributing to elevated and cumulative trauma exposure, which compounds existing trauma and disparities. Some additional things that we have seen, that there's definitely a need for care coordination and navigation, especially since we're not having the same level of access and observation of the needs of the families. The importance of somehow being able to insert a family-driven systems of care and maintaining communication with families so that we can do that in order to address some of the systems issues that they are facing with us, which include closed schools, minimized pediatric visits, reduction in CPS reporting, or child protection reporting, and for some of our most vulnerable populations, including loss of services for children in foster care and somehow involved in the juvenile justice system in the community. Those populations have been particularly sort of an additional sort of hit for them. And the real need for community-based services to have more resources for telehealth and being able to coordinate and navigate and focus on the needs of these families in some new innovative way, which we're in the process of trying to address. One of the things that we recently wrote about is the importance of healthcare regulations and reimbursement strategies to help us with this collaborative care and prevention strategies across sectors. And we might have some opportunity to take advantage of the technological advances that we have seen, at least during this pandemic. And perhaps these can support these cross-sector partnerships. And that's one of the things that we're trying to capitalize on in innovation. So for example, Dr. Toulouse Shams, who's here at San Francisco General UCSF, is piloting and studying a solution which is around community academic partnerships using a telehealth learning systems hub in connection with that. So if you look at the diagram that I have here, you can see that some of the components are, if we work with, for example, the foster care families, to have a foster care family navigator is what we're piloting, and then a family telehealth project. Combining these two things, we're hoping to be able to have more connection with the families and looking at what are sort of the family-centered, even foster care family-centered needs. Adapt family-based interventions for telehealth delivery, using informants or information from key stakeholders and families, and looking at the impact on caregiver-youth relationship, quality, and youth residential status, so that hopefully they don't have to go into residential. We're also looking at, on the other side, looking at stakeholders from the court and child welfare to also look at some adaptations and development of the intervention, and then developing a foster care family navigator model using the information from these stakeholders to pilot a mental health symptom and service utilization focused intervention, and looking at the outcomes. And also using other technology like text messaging, annual interviews. The point is to be able to connect with families in an evidence-based way, in a family-centered way, and also using a telehealth learning system hub to build capacity across systems around using teletechnology. And this just goes over a little bit about what we're thinking in terms of family mental health care navigation. Again, if you look on the left of the screen, the project will involve creating a navigator protocol of how to work across these systems, a healthy SMS, which is a text messaging dashboard communication portal to help with this communication, and then a motivational, interviewing, consistent approach. We're hoping that this will help publicly insured youth and caregivers be able to have more satisfaction, that there be more usability of these sort of technology systems, improve barriers to care, and continue to motivate for youth treatment. We're hoping that this will improve the identification of mental health needs, especially if there's escalating need, decrease transition time to referral, and retention of families in care, even with this sort of different type of more virtual telehealth navigated model. And it really requires a participatory research approach, which includes child psychiatry. So that's where, the CAPS, child psychiatry, we're in this, looking at it with pediatrics, emergency medicine, nursing, schools, and public health. And to be able to create, again, this multi-system collaborative approach that's family-centered, and really tries to create some solutions that we may need in the long run. And this just also talks about, the elements of this navigation. So we're hoping to use this collaborative technology-supported method to be able to screen, assess, identify kids that might be in need or escalated need, help with the navigation on referral, following them and making sure that we're supporting them around initiating treatment within this model, and continuously engaging them so that we can continue care and hearing what their needs are throughout every step, so that we can minimize the amount of children that might be falling through, especially during this time. One of the things that child psychiatrists can do is definitely through our academy, really support these congressional priorities around telehealth, mental health services to be paid across insurers, make sure that the relief needs are permanent and post-pandemic, because there is a lot to be gained in continuing to develop this modality of care, and making sure that there's support for low resource communities in terms of technologies, Wi-Fi, connectivity, that we need to continue to push forward for, especially in most under-resourced areas and communities. And then I just wanted to really end with the importance of our workforce. We know that, the clinical environments have been really transformed during this time of COVID-19. And we've talked a little bit about what people are calling the syndemic, which is really, this pandemic, plus the addition of a lot of sort of focus and awareness of the exacerbation, but the chronic issues around structural racism. And some of the things that we're looking at in terms of all of this innovation is the importance to really look at, the impact on our workforce, many who are from the community, and especially if we're working on community, academic, cross-sector partnerships. We really need to focus on transforming clinical environments to be inclusive, responsive, empowering, and safe for people of color and anyone facing discrimination. And some of the things that we have had to be really conscious of is having very frank conversations with our community partners about where there is burden in that area, and how do we think about the structural issues that impact not only our patients, but also our workforce. We need to take into consideration the burden on trainees and providers of color, who have been describing that under this extreme stress of trying to come up with solutions, that they really, have been at risk of experiencing vicarious trauma, and especially in almost sort of a moral injury, in the sense of feeling like there's not enough that they can do. Some of our providers, which I think is very important to have training about this, were not sure that the tele services that they were providing were going to be enough for the level of complexity seen by the children that they serve. And so, having peer support and adequate supervision and training about what are the things that we can do successfully using remote access services, as well as learning of how we can improve that, and working collaboratively so that we can sufficiently monitor and take care of children as multi-system partners is important. And then the other piece is the cultural humility piece, because obviously, as we have worked with our community agencies that are providing such important essential needs for our families and children, we have to have sort of an approach of cultural humility, where we're really looking at what are some of the natural resources also in the community around healing. And that can go everything from sort of religious to cultural practices. And so the importance of having that stakeholder input with this humility of how we design interventions and engage with the community, because they have really stepped up in a similar way like Kay was talking about in the rural areas. But we have to be able to work with great respect for one another, and understanding that there are multiple ways of looking at healing, and working with the community in regards to advocacy and implementation for those essential needs that they have identified. Disparities in technology access will impact telehealth. So we really have to increase video technology access for clinicians and patients, having reimbursement for these services, sharing of information and care coordination across the spectrum of care. Community academic telehealth partnerships are another option of improving mental health abilities of services within schools, and to be able to partner in that care, helping teachers sort of also figure out how to do these things from remote access. Cultivating existing community strengths in CBOs and schools, support public hospitals as primary places of care for disenfranchised communities. And again, collaborative care with schools, even remotely, especially now when we may be in and out at minimum of remote education. And this is just a little message on a wall here in the mission. Dear God, please bless my family and friends and the entire global community as we go through this crisis. Let no harm come to them. Gracias. And I think that's a sentiment that that's in the community, and opens up the opportunity for partnership if we will take that opportunity.
Thank you so much, Lisa and Kay. I was thinking it might be nice if we had just a few minutes of conversation about it, about what each of us has learned. One of the things I was thinking about was how do you guys think that with the natural disasters coming, with hurricane season around the corner, and also the many natural disasters we've experienced and in hard-hit communities, how do you think those two things intersect, the COVID and communities that are sort of recovering from and facing natural disasters?
This is Kay. I guess I've thought quite a bit about this since I have lived in a disaster zone for a long time. And in North Carolina, before I left, I was working in a disaster zone after the 2019 hurricane. And so when I left there and returned to the mainland, I was asked to work with the North Carolina Psychiatric Association and the North Carolina Child Council on their disaster committee. And they had daily meetings every morning from about mid-March until sometime into May. And there was a lot of talk about how to help communities that are already in trouble because of disasters, still trying to recover, when there was another disaster of COVID and then potentially other natural disasters coming right after. I must say that we were very, I'm not even sure I know what the word is. We were all taken about actually speaking with stakeholders like Lisa was talking about, who came on some of our calls from these areas and told us very inspiring stories, but also worries. And I think as a psychiatrist and as a citizen and as a human, it is very challenging trying to understand as a psychiatrist how to continue to help people through these times. And it's made me reflect a lot about kind of what to do. And I know Lisa has a lot of family and friends in Puerto Rico, and she too has been involved with a lot of disaster work. So I'd like to hear what she has to say.
Yeah, I mean, I would agree. I think it's, I'm in constant contact in Puerto Rico, which, took some control over COVID-19, and they were able to flatten their curve in the beginning. And then people started coming in, and people started getting tired of, being on lockdown, as they put it. And they're starting to have some spikes again in their COVID-19 rates of transmission. And that's been really challenging because Puerto Rico already, I think what's so challenging about our communities that we're working in, it's natural disasters superimposed on already tremendous amount of disparities and economic issues that everyone's already facing and struggling with. And then you get hit with a couple of disasters, right? Because Puerto Rico had a couple of hurricanes and then some earthquakes to add to it. And then the COVID-19, which closed all kinds of things, all kinds of services and restaurants and everything else that people need for their livelihood. And they're scared because, one, they're not sure how much more can people take, right? Communities have, in all of these circumstances, stepped up, like we're seeing in COVID-19. But, we have to figure out a way to sort of economically support these communities, right? And be able to provide resources, because how much can we ask people to do with limited resources? And I think it is hard. I think Kay is pointing out to something, that this is something that we have to do as an academy, as a network of even child psychiatrists, because I think it can become disheartening for us. Just like I was talking about the providers at the end. Like, what else can we do? There's so much against the communities that we're serving. We're just a little child psychiatrist, right, trying to do something. But we have to partner, and it has to be sort of, I think it has to be a movement of really trying to figure out justice for those things.
Yeah, and I think you're right. And I think for me, it also, I keep coming back to this issue of these disasters really not only really shining a spotlight on the disparities, but widening the gaps,
Mm-hmm.
and I think the same thing is happening with COVID. And so when you think about the kids that we take care of, especially the kids with really serious emotional disturbance, and serious issues and multi-system involvement, they're impacted even more. It's so unfair. And I feel like also as a human, as a citizen, it's almost weirdly easier for me as a privileged person to bury my head in the sand, and I think that that it's easier to remain privileged also. So not only do I feel like, I don't think that's good. I think we have to really fight that. And I think that we really have to make a very explicit decision as people who are fortunate in many ways to really make an effort to reach out and to work with the most vulnerable individuals, because I think that the gap is widening, but it's also easy to kind of ignore, I think, for a lot of people.
Yeah, I appreciate what you just said, because I think that I have had very similar thoughts, that it could be easy to put your head in the sand, but we really have to continue to not only understand more, but we have to really advocate more than ever for the kids and the families that we work with. Because what Justine and Lisa have just said is worrying me so much, is that I am seeing families go further in debt, further in trouble. And these are families that were already struggling. And another thing that Lisa said was helping our workforce. I think it is very important for our committee and every ACAP committee and the ACAP leadership to really try to help to support our workforce and all the people that help kids with mental health and pediatric care, because the people that are doing this work everywhere in the United States, it's easy to get stressed yourself when you're trying to help people that are further in trouble. And I'm not sure how much support child psychiatrists in the middle of nowhere have anymore. We really need to reach out to our membership and to find out how we can help them.
And I would just underline too, the other day I was saying, I sometimes just want to crawl under a rock, and just take a little rest under there for a little bit. But I think as CAPS, we do need to support one another. I think there is a network of us and across committees that are engaged in some aspect of this work, because it so crosses so many things, right? That everywhere we practice, right? And so I think it's important to, find a way to support one another. And also just kind of show up. The way that I sort of have pushed myself is to go to that mission hub where they're providing all these services. And even if it's that, I need to sort of help hand out some of the food, right? It might seem like, oh, whatever, what's that going to do? But I think I have to be able to sort of sit with all of what it means to be able to have the kind of dialogue and partnership that fuels my understanding of what we need to be advocating for and what we need to start trying to implement together. That's all I can do.
Sorry, didn't mean to interrupt you, Lisa. I was just going to say, that reminded me, thinking about also kind of who gets to telework, who gets to telework and who has to go to work. And the whole thing about sort of supporting staff, because, it's hard to support staff who are working kind of really directly and kind of in the line of in danger when, when you are sitting in an office teleworking. And I am, not saying that, I'm not trying to make anybody feel bad or be judgmental, but I think it is really important to sort of honor that there is sort of an injustice, I guess you could say, about who has to be, experiencing some risk by being present, and then for whom it's a choice. So that's another thing I think just to think about.
Yeah, and I think that's something that we've struggled with, because I mean, even in our department, you know, UCSF is a large department across multiple campuses. The general, you know, some of the work that we're doing is direct outreach work to the homeless population with serious mental illness, and that staff has not been able to do a lot of remote work. Right? They have to actually go out into the street and help people, right? And we can't even have them come into our center because of the distance that we have to keep. So we've had to, you know, give them phones, try to find a way, like, how do we sort of keep connection with people who desperately rely on the supports and services that are essential. And we have an African-American team, a Latinx team, and a Chinese speaking team that goes out to sort of work with that homeless population. And they haven't been able to really shelter in place, right? That staff, right? They have to go out. So I think when we think about our systems of care and leadership, one of the things I've had to do is reach out to them. And my job was how to keep them safe, how to have PPE, how to make sure they have the essential needs. You know, I got donations from everywhere, like feed them, right? You know, to feel taken care of. I've almost had to have like sort of this trauma-informed response with my staff of, am I taking care of your basic needs, right? Can you circulate time for rest? How can we have time to do sort of self-reflection and support for what's happening to us and overcome vicarious trauma? They've also seen increased deaths in their population, right, during this, not just because of the virus, but because of people overdosing more, suiciding more, because of the closure of the essential services that they rely on. So I think we have to sort of almost treat our patients, but also our own staff and faculty in a trauma-informed way, right? That we care, that we're hearing, that we're trying to deal with their basic needs, and that we understand what's going on and we can listen to that difficulty.
I also appreciated what Lisa said earlier about all of us thinking about our colleagues who are of color, because I am obviously white, but I have colleagues of color, and I think they have been under more stress in a way. It seems like, and you know, we've had conversations about this on our community, in our committee, excuse me, but it seems like now leadership is asking the physicians of color more questions, but I'm not sure if they're supporting them or really giving them a voice, which I think is really needed now to help our systems change. And I know that APA has a town hall, I think it is, on structural racism soon. I'm hoping ACAP has something like that so that we can learn more, so that we can help advocate for our colleagues and for the systems that we work in, so that we can really change, because so much of this has to do with the structure of our organizations.
Yes, I mean, I completely agree with you. And I thought about it a lot. I mentioned when I was talking in my presentation that the milieu staff at the organization where I work is almost entirely African American. And all of this was occurring in the context of what happened, the murder of George Floyd. And so I felt in a lot of ways there were such echoes of what the staff was upset about and what the staff was feeling, you know, that traumatization that people were feeling with what was going on kind of more broadly in the country. And so I think it really, hopefully it'll lead to some good change. But I do think that some of the structure of our organizations really do need to change. And we, need to think about kind of what role we play in kind of promoting promoting that structure.
And maybe we can, Kay, put a plug. I know that you're facing potential hurricane coming over, and we are entering hurricane season and fire season and all kinds of other things. So to be on top of everything else. So we wanted to put a plug. The Systems of Care does have a new disasters module on the website that goes over a Systems of Care approach to addressing disasters. And there's some information there around thinking about COVID-19 as well. Kay, I don't know if you wanted to say anything else about it.
Well, first I want to thank Lisa because she was the primary author and she worked very hard. And I want to thank ACAP for helping support that effort. And I want to thank the webmaster for putting it on the web yesterday or today. So everybody can go to the ACAP website, and we will ask that be put at the end of this presentation so that you will see how to obtain that module. And it has lots of helpful information.
Great. Well, I think we're almost out of time. So I just want to thank Lisa and Kay for your wisdom and your thoughts today, and look forward to ongoing communications. Thank you.
Thank you.
Thank you.